Thank you, Colonel. My introduction to this talk actually came from Dr. Lim, and as he was asking me to come, I was thinking, well, you're the better person to give this talk than me. I'm honored. So the other thing is, I thought about this is, as the Colonel just mentioned, a lot of the things that I have to say are about what we learned from the longest war in U.S. history. I thought I'd put the silence on that thing. And that is, how do we get patients back, soldiers, civilians, children, to a place of safety? And one of the things that he mentioned in his closing slide that I think is apropos is, what is the feasibility? So I have no disclosures, and there's a usual thing about the Department of Defense, and may have come this to no confusion to you that I am not Ukrainian. So some of the things I will say will be based upon opinion versus actually being inside the country. So this is where I work, and this the skyline, for those of you who are familiar or not familiar, is the Chicago skyline. At the bottom of the slide, the tallest building behind the castle is the hospital at the University of Chicago. So that's the undergrad campus with the hospital. Lake Michigan, at its widest point, is where the hospital is about 300 miles across the other side is obviously Michigan. That's why it's called Lake Michigan. So, to kind of talk about these hypersonic missiles that were just kind of alluded to, just to kind of was talk to you about the distance over a country. I'm going to kind of give you an example of, laparoscopy, right? So this is a tertiary center. We do transplants, we do trauma, we do all the things that need to be done. And if you imagine that someone fired a hypersonic rocket just from the other a missile just from the other side of Lake Michigan, so that you're talking Mach 5, you're talking about a mile almost per second. And you're talking about a huge blast wave. And if you look, there's not a lot of high buildings between the University of Chicago Hospital and the other side of Lake Michigan. So, anybody with a computer could find a grid and hit that hospital. Of course, in a minute, your capabilities are taken out. As hospitals are being targeted, you can see that this becomes a problem. And it becomes demoralizing for those who actually want to give high-quality care. So just as an example, a country that has infrastructure like and well-trained surgeons like Ukraine, how very quickly you can become to a very primitive situation. So laparoscopy in war is not anything new. For the sake of time, I won't go through it all, but on both sides of the ocean, two people on different sides of the fight came to the same conclusions, that laparoscopy could be used. A lot of the only winners in war seems to be medicine, but the idea of a scope, the ideas of trocars came on board. Then on the American side, you actually have not only diagnostic laparoscopy, but you now have therapeutic diagnoscopy. And if you go to the last couple bullet points there, you can see we have academia attached to it, that you have almost 1,500 cases where peritonoscopy, which we now call laparoscopy, is done, and actually it reduces the error rate. So there's a lot of feasibility and a lot of reasons as to why, as you saw in some of the video, that if you put the scope in, not only can you be diagnostic, but you can also now become therapeutic in a war zone. So what do we learn from all these lessons of war? Well, we've gotten better at getting people off the battlefield. We've decreased the death of wounds. And during the Vietnam era, what was once a prolonged evacuation, you have helicopters buzzing all over the place, and the fatality rates actually get down about 9%, even though you have rockets and other explosive devices moving around the battlefield. I literally, along with Dr. Doucette, I see sitting down front, probably got this same thing from the Maddox conference, right? Anytime, you go to a conference, you start getting from the vendors, you should try this product, Reboa, inflating a balloon to stop hemorrhage. Now, here's an example of one of those things that just keeps trying to come back. And I can tell you at the last meeting, it was wholesalely condemned. But this is what we find. In the military, we see something that works. Reboa came along in the Korean War. It was tried for some of the most fatal injuries, junctional injuries of the lower extremity going to the abdomen, the large vessels of the abdomen, and it just didn't work. But just like, I mentioned Reboa 60 years later is still condemned, I think laparoscopy is going to be different. We're going to see that as the instruments get smaller, battery operated, the monitors get better, augmented reality, that we may be able to do those things. This was already shown, but what we figured out from our conflict, the longest one, that if you could get back to these hospitals and all the way back to the Roll 5 out of the country, that soldiers do very well. So here is the Department of Defense Trauma Registry. There were almost 190,000 surgical procedures done, and the majority of them were done at the Roll 2s and Roll 3s, where, again, it was mentioned that we enjoyed air superiority. And if you look at the common operations that were done, you can see the most common one being bowel injury. And it says laparoscopy otherwise specified, and others, I don't know exactly what that means, but I used to call them the ectomies when I was over there because, one blast would get you a gastrectomy, nephrectomy, pancreatectomy. So, it's kind of hard, and you can see by the numbers to imagine laparoscopy that far forward. So here's an example of a Roll 2 that I inherited once in Afghanistan. In Iraq. And, I kind of think about this. If you blow up a hospital in Ukraine and you have to rebuild it, you may end up with something like this. It's probably not this type of plant growing in since it's the desert, but you rebuild. And this is kind of what the Roll 2 looks like. So that's the Army side. That medic, she's probably about 20. This is 2005, somewhere around that. Very young. You can see the kind of side of my head with the light that's very primitive. And then you go to the Roll 3, Air Force, and you cannot distinguish it from a hospital back home. And it also makes me realize that I joined the wrong branch of the military. So if you look at the abdominal procedures that were done, you can see only laparoscopy was done in 18 of them. So you can see it does not seem feasible at this point in time in the forward echelons, especially, and that should say, that the Roll 2s only had 4 reported. So here's Afghanistan almost a decade later. You can see this is the Navy hospital, once again reinforcing that I'm in the wrong spot. That's actually their trauma bay in making their ORs even more spectacular. If I had a picture of them, I would show you. So on that same base, we have the Special Forces compound where I was stationed, where we go out with obviously a smaller team, and we load up our gear on the back of a Chinook, and then we fly out to the resources, the recesses of the country. And so this is what a heavy mission looks like. This is the stuff that we carry when we're taking with us. We go pick it out of the shed, we put it on the stretcher, we take it out to the razor, and we load it onto the back. And then this is actually your surgical team. Now, I say, now let's think about this. Which one of us wants to carry the pressurized vac tank for laparoscopy? Who's going to stand next to that individual? So, this is really what makes it hard to imagine in these forward echelons for that. And this is a different cartoon than what Robert showed, but you can see it's pretty much the same thing. They are dug in where they are. And the closer you get, the deadlier it gets. We do not enjoy air superiority. And this is what, looking at another study coming out of Ukraine, looking at the dilemma that they face. So you can see, even at their main military hospital, there are large numbers of casualties coming in with limited evacuations, as previously stated. And they thought to understand their own patterns of injury. And like us, the NATO evacuation kind of follows that tiered response. And we've already looked at this. Now, let me actually go back. Now, that's what we did, and we did it very well. This is what a large combat scale operation looks like. Don't expect you to memorize it, don't expect you to know it, but you can see it gets a lot more sophisticated when you don't have freedom of movement. And if you see, and we've talked about these peer-peer and near-to-peer wars, 21,000 casualties a week. It is estimated in the first 2 weeks if the United States were to get involved in a war, the Soviet Union, China, this is what it would look like for us. And there are not a lot of, I shaved my hair. He's got gray. I just shaved mine. But, there are not a lot of guys younger than us coming along, right? So you put us back out there. We're willing to take that risk. But the risk is very real, and it's very hard to find our replacements. And what does that mean? As already mentioned, prolonged field care, blood, damage control surgery, and not really definitive care being taken care of. Just like in Afghanistan, you look at the early conflict and the current conflict, blast injuries lead the way in Ukraine. And here's what we found. Robert showed you pictures of limbs being blasted off. Limb injuries account for 65% of the total injuries in this study, and that just keeps increasing. And you find that gunshot wounds don't go up, but they go down. So we're talking about gunshot wounds go down as blasts go up. So the further you get away from the blast, you're going to survive, but you're going to get these ballistic injuries. And I think that's where your laparoscopy comes into play. Because if you get a penetrating injury, you may actually survive this. And this is where laparoscopy has the role, as is already shown in the cartoon. So, but here's another concern. Again, it's very hard to get an evacuation away, right? You have people surveying the field, the battlefield. You also have drones that can actually target any evacuation. So you're flying, you're moving by ground, and all of a sudden a payload is coming from over the top of your head. You know, in Afghanistan, we got used to looking down to make sure you didn't step on something. Now you have another conflict where you have to look up, and you can't look high enough. So that's the problem with what's going on. There's been numerous attacks, numerous fatalities, and makes the evacuation even more dangerous. So I think battlefield laparoscopy has a role. I think you have to think about, can you move it back? And if you move it back, as I mentioned, a hypersonic missile, can you protect it? It has a role in the forward setting. That's why I say feasibility, because remember, this is preserve the fighting force, right? If you're sending someone all the way back, they may not come back to fight over an army that's dug in and is well trained and has larger numbers. So I think it has a role for screening. Definitely a role for diagnostic, and I think the future role will be for therapy, but I think adjacent to the battlefield, that's going to be almost impossible. So this is, an example of something I did in the United States, right? CT scan, which you may not have, shows that the colon's in the chest. You stick a scope in as just like pulling out a missile, then you can go out and fix that, and that person can go back to battle as soon as possible. So remember, preserve the fighting force is the reasons that we can do laparoscopy, the reasons we should do laparoscopy. Never give the soldier the wrong operation, but if you can do diagnostic laparoscopy and continue laparoscopically, you should. So, in summary, laparoscopic injury for penetrating injuries eliminates the role for an open procedure. It should be done. I think with the reach of missiles and the dug-in status of this current conflict, that the Role 3 designation is going to be redefined. We should do the best that we can to minimize, ruggedize equipment, get it closer to get people back to the fight. And I think just like the feasibility of every war, we learn something new. I think MIS, unlike RABOA, is here to stay and only going to get better. Thank you.